Okay, we are live now. Hello, everybody. Hello, Prof. Ahmed Badrati.
Hello.
Hello, Dr. Franzizo.
Hello.
How are you? I hope you enjoyed this great webinar from our great admin, Prof. Ahmed Badrati. Yes,
Thank you,
with
Dr.
our
Ahmed.
great pleasure and honor, we introduce you our last speaker, the founder
Thanks a lot.
and the admin of this great group, Excellence in Endodontics. Let me introduce Prof. Ahmed Madarati with his biography. Prof. Madarati is a professor and consultant in endodontics in Tiba University, Saudi Arabia. Prof. Madarati attained his PhD degree in endodontics from the University of Manchester, United Kingdom, 2010. Prof. Madarati was ranked as one of the top 5 young researchers in the health and medical science and was the runner-up of the 2011 Scopes Young Researcher Award in the United Kingdom, which was developed by Elsevier in association with the US-UK Fulbright Commission. Prof. Madarati has over 50 publications in prestigious dental journals and associate editor of the European Endodontic Journal and an advisory board member of the Saudi Endodontic Journal. He is also an official reviewer for several prestigious journals. Prof. Madarati has been extensively supervising continuous education and hands-on courses, lecturing internationally, and he won many awards as best speaker and for best presentations. Prof. Madarati is the founder of Excellence in Endodontics Group. He and his excellent team have proudly brought the group to an excellent level of success, as it has been the fastest growing group on Facebook with over or almost 100K members, 100,000 members. Before the starting of this webinar, let's welcome our platinum and gold and silver sponsor. Let's start first with the Zark. And let's welcome our next sponsor, Dinjoy Company. And we would like to thank our next sponsor, Coxo and Dix's company. And of course, our bronze sponsor, Ramo and Aitif. Prof. Madarati, you can start your webinar.
Thanks a lot, dear Dr. Abida. Thank you, Dr. Vincenzo, for the kind words and the kind introduction. Please let me know that the presentation, the PowerPoint is working well. Is it working?
Not yet. Please share your screen.
Yeah, you should share it. Yeah, the screen.
I need to
Please share your
share.
screen.
Let's share screen. Okay.
Here we go.
I assume
There we go.
that
Yes.
Here we go. Here we
it
go.
is working now.
Yes,
Perfect.
it worked.
Yes.
Hello, everyone. As Dr. Ababida mentioned, it's my great pleasure to be one of the speakers in this the sixth online conference of the Excellence in Endodontics Group. It has been really great pleasure to share the stage with the eminent speakers worldwide. Thanks a lot to all our speakers, moderators, the Excellence in Endodontics Group, team group, and the Excellence in Endodontics members for interacting with this conference. And I hope that so far you enjoyed and you found it beneficial for all of you. My presentation today is about what we think, some aspects that we think are correct, or there is a kind of misunderstanding or misperception about these aspects, and I'm going to clarify some of these aspects. Let's start with the taking radiographs during pregnancy. There is a kind of like general assumption that, and unfortunately, it's kind of a practice in daily endo that pregnant should not receive any root canal treatment, or at least they can receive root canal treatment, but without taking radiographs, which is completely incorrect. So this is what we believe, that no radiographs during pregnancy, and the fact that we can take radiographs and we can do RCT with radiographs during especially during the second and the third trimester of the pregnancy. Ubaida, I think you need to go off, Mr. Ubaida.
Yes, I can hear you.
Yeah, just you need to remove yourself from the show, please. Okay, thank you.
Okay.
And this is,
Okay.
by the way, this is a global issue, by the way. And here, for example, there's one of these, this study, which has been conducted in Tabriz in Iran. The results that only 28 scientists were aware that diagnostic radiation do not result in developmental anomalies or mental retardation. 58% only were aware of the threshold radiation doses, which is 25 rads for pregnancy termination. And the conclusion of this study, that dentists seem not to have the sufficient knowledge about the diagnostic dental radiation risk during pregnancy, which necessitate the attending postgraduate courses. Another study that was published in 2016, the dentist, what they found in this study, that the dentists who attended continuous education program had better knowledge compared to those dentists who did not do so. And that difference was significant. Among those who attended the programs, 93% almost were aware of the safe dose of radiation, and 62% were aware of the threshold radiation doses of pregnancy termination. By contrast, there was no differences and practice regarding radiation risks on pregnant women based on their academic qualifications. So again, the postgraduate continuous education is an important factor in increasing the awareness of dentists regarding the radiation of pregnant. The conclusion, the level of knowledge among dentists was satisfactory. We have to notice that it was satisfactory, but not that good. Continuous dental education regarding radiation protection principles and its risk on pregnant women is required to ensure maximum safety both for clinicians as well as pregnant women. Some facts of the literature, that most of the biological response to radiation occur during the first 2 weeks. Some articles, they mentioned during the first 7 weeks, but the majority agree that it's during the first 2 weeks, which is a period when the mother is unaware of her pregnancy. And these responses led to miscarriage of the fetus. Therefore, there is no any concern about congenital abnormalities during the first 2 weeks of pregnancy. If we want to know about the amount of dose that we usually use for dentistry and endodontics, the intraoral dental X-ray imaging procedure requires 1 to 8 microsieverts, while panoramic examination required 4 to 30 microsieverts. Cephalometric required 2 to 3, and the CBCT procedure may need 50 microsieverts or below, or it might need 100 microsieverts, according to whether we are taking full CBCT or limited view. So we can see from these numbers and what is documented about the dose that is for pregnant, it is estimated that 1%, only 1% increase in congenital abnormalities subsequent to an exposure of 10 rats, which is 100 microgray, which is 100 milligray, actually, not micro, which is far below the dose that we are using in daily endo. Since diagnostic doses are less than 10 rads in dentistry, such abnormalities cannot be attributed to dental diagnostic dose. So any abnormalities, any congenital deformation, it cannot be attributed to dental diagnostic doses. The fetus does not directly receive the radiation dose during head and chest diagnostic exposure. As we know, our X-rays goes to the teeth, the upper teeth and lower teeth, which is far away from the fetus tissue. Women who were unaware of their pregnancy and who had been exposed to radiation, there is no need for pregnancy termination. This is very important, especially in the Western countries, because they believe that they have to terminate the fetus. No, they don't need to do that when the exposure dose is less than 10 rads. The maternal tissue covering the fetus also reduce the fetal dose to 30% of the abdomen skin dose. So what is the fetus usually receive from the X-ray dose is 30% of the doses that reach the abdominal tissue of the pregnant. Use of lead aprons can also reduce radiation to 98%. So no radiography procedure should be carried out on pregnant women unless there is an absolute necessity. This is what we usually do. And this is what usually pregnant women, they don't tend to receive dental treatment, or let's say routine dental treatment. They only seek the dental service when there is emergency cases. This is a kind of fact. And when we do that, all the techniques of protection, we follow all the techniques for protection. So in summary, pregnant women can receive dental treatment considering the basic principles and the possibility of carrying out radiographic techniques during pregnancy by considering protective measures, awareness of the safest period for radiography, which we mentioned after the first 2 weeks, and the dose involved in diagnostic procedure. Especially nowadays, the majority of dental clinics, they are adopting digital radiographic systems, which cause very limited of radiation compared to the conventional radiographic systems. I will shift completely to another aspect in endo, which is about using the pair. All of us in our daily endo, almost we are using what we call it the non-cutting tip bears, and we believe that they are safe, but in reality, they are non-safe, and they are just pilot bears. I will give you an example. This is what the manufacturers usually promote their products. They call it safe, but is it really safe? I don't think so. And we should call it pilot tip rather than calling it safe tip. It's not safe tip. It is pilot tip. Here is an example. This case was dealt with one of my students. We can see that it's a straightforward case, a lot of coronal tissue, okay? But unfortunately, the student assumed that because he was using a pilot safe, pilot bear, he assumed that it is completely safe, and this was the result. And this is radiograph after access cavity preparation, and we can see that the tooth deemed unrestorable. So the case from straightforward case to unrestorable case, just because the clinician assumed that the pilot tip are completely safe. So please be aware that these kind of tips are not completely safe. They can damage. We can end with a catastrophic result, as we can see, if we are not using these types of bears carefully. This is another result, what we call it the gouging preparation. It was also as a result of using the non-cutting tip bear, and such cases it is really are really difficult to find the root canal orifices unless we are using magnification. Also, there is a kind of misunderstanding about the difficulty of the root canal anatomy, and most of dentists believe that only interference with the inferior alveolar nerve is problematic, while all posterior and posterior teeth are problematic. And here this will bring us to the what we call it neuropathy. Sorry. What are the symptoms of the inferior neuropathy? Allodynia, which is pain to touch or cold, hyperpathia, hyperglacia, and paresthesia, which what we think this is a kind of disease. In reality, paresthesia is not a disease. It's a symptom of neuropathy of the inferior nerve, and tingling or formication, or maybe the patient will feel burning or shooting pain or electric shock. What are the common causes of the inferior alveolar nerve? In 1% of the lower premolar RCT, it might cause the injury of the inferior alveolar nerve. And this is one of the cases that recently has been referred to me. The patient received very good root canal treatment, but unfortunately, for the last 9 months, he has been he has feeling no sensation in his lower lip, and which is paresthesia for the last 9 months. Going back to the history and the dental procedure, he mentioned that during the root canal treatment, he felt with sharp. So with such a good root canal treatment, as we can see, we assume that it was root canal treatment, and we can see that the sealer is filling the laterals, and there is a kind of, let's say, a lovely puff at the end. But even though the patient has paresthesia for the last 9 months, and according to what he mentioned, I assume that the reason for that, for the paresthesia, is a kind of extrusion of sodium hypochlorite. The point here that even though the apex of the premolar is far away from the inferior alveolar canal, but even though the injury occurred and it's not recovered for the last 9 months, and unfortunately, as we will see, that some of these damages might be permanent, and the patient has to live with this kind of injury forever. So, treating lower premolars has been reported to be a cause of the inferior alveolar injuries in 1%. In a study that conducted on almost 2,400 patients, it was found that 7% of the patients sustained chronic neuropathic pain after a single endodontic procedure. So here, what is the message here? Whenever you are going to treat a patient, lower premolars or lower molars, it's very important to mention to the patient about the complications, the possible complications, which is one of them is that will resemble as paresthesia. This is one of the symptoms, as we mentioned. And this should be mentioned in the consent form that this is very important. What are the common causes of damage to the inferior alveolar? The first and most common reason and cause is the third molar surgery. Local anesthetic injections has been reported to be the second most common reason, and implants, and endodontic procedure, which was 8% of the cases. It has been reported to be the fourth most common reason for the damage of the inferior alveolar nerve. Ablative surgery, trauma, and orthognathic surgery might cause such injuries. What are the factors that which are related to endodontic procedures? The toxicity and mechanical pressure, irrigants, intracanal medication, obturation materials, all of these can irritate the inferior nerve. Paraformaldehyde materials are most common associated with this injury. So please, for those who are still using these kind of materials, please stop using them. Most endodontic materials have a very high pH, which result in immediate nerve damage that might be, by the way, permanent, and this can mean some injuries that might stay permanent. Apical hemoglobin irritates the nerve, which is due to the ion content. As a result, this is the end result of bleeding in some cases. Mechanical factors which repeated over instrumentation, and here is the importance of the apical control and the accurate measurements of the working length and the sticking to the correct working length. And finally, the thermal factors, which might be as a high temperature due to the obturation, long procedure of thermal obturation, or even prolonged activation of the ultrasonic tips. All of these endodontic procedure might lead to inferior alveolar nerve injury. How to prevent? Simply, we need to know some facts. As I mentioned, that whenever are going to do RCT for lower posterior teeth, premolars or molars, you have to expect complications, especially with the second molar, because they are the most common for inferior nerve injuries because of the close proximity to the inferior canal, as reported, and usually the distance is less than 1 millimeter. We need to know that the presence of bone between pieces and the inferior nerve canal doesn't necessarily prevent the injury, and this is one of the big mistake, or let's say big misunderstanding, that we think that there is a bone and there is a long distance between the apex and the inferior canal. So we are not in the safe side. Why? Because cadaver studies showed that there is no compact layer of cortical bone surrounding the inferior alveolar nerve sheath. In some cases, a slight denser cancellous bone was found, but it was rebuilt with multiple perforations, and this can explain a lot of inferior nerve injuries, especially with sealers. For example, here we can see, we think once we see this view that the sealer is inside the inferior canal, but in reality, it's outside. It is proximal, very proximal, not inside. But even though it caused injury, toxic products can easily diffuse the trabecular spaces that surrounding the nerve bundle. We can see here that this is the inferior and these spaces, trabecular spaces, can be filled with the materials that we are using in endodontics that will extrude, and they can easily irritate and cause the injury to the inferior nerve. So again and again, please do not assume that the nerve is protected by dense bone. In majority of cases, there is kind of these trabecular spaces which the endodontic material can reach and cause irritation to the nerve. What are the predisposing radiographical factors? When can we expect such injury? We should expect such injuries in all, especially in cases where there is resorptive defects that communicate the canals with the external root surfaces. That means there is communication canals and the surrounding bone. Suspicious of perforation that communicate with the external root surface, as we mentioned. Root fractures. Whenever detecting root fractures, we should avoid inserting any materials within the canals. We should make sure that there is no root fracture. Otherwise, you know that the treatment of choice is extraction. When we have dense invaginatus in lower teeth, endodontic apical lesions, whenever we have apical lesions, that means the extruded material will easily reach the inferior nerve and cause irritation and damage, especially of premolars and lower molars. What are the treatment of such injuries? Of course, when we have severe damage, means the surgical management is the first option, either by the maxillofacial surgeon or the neurosurgeon. It's not our job. Permanent injuries may necessitate antidepressant therapy. As we mentioned, in some cases, very few cases, the injury might be permanent. So the patient has to adapt with such a situation, and they might need antidepressant therapy. Steroids may maximize the recovery of the injury. It might be given 50 milligram for 5 days, or 10 milligram, or even 5 milligram. There is no agreement in the literature regarding this. High dose of non-steroid anti-inflammatory drugs, the best 600 milligram ibuprofen or the alternatives. Vitamin B, there is no agreement on its efficiency and whether it's beneficial or not, but it is claimed that it is useful in such injuries. Now I'm going to present a case of lower inferior nerve injury. A female, 25 years old female with lower right lip. She claimed that she had RCT initiated 2 months ago at a private university clinic. The RCT was completed a month ago by a general dental practitioner. During the treatment, she felt sharp and painful while cleaning and shaving. 1 week, the dentist prescribed antibiotics for 1 week and anti-inflammatory following the RCT. Even though the patient start feeling paresthesia 3 days after the RCT, she is feeling electric current sensation sometimes since the RCT, and the patient believed that the chief complaint, which is paresthesia, is due to a fractured file in the tooth that received RCT. What I found that there was no response upon probing of the gingival or the lip. Soft tissue or the intraoral soft tissue were within normal. The radiographic examination revealed to some extent good root canal treatment with overfilling in the distal root and a fracture instrument in the mesial canals that measures about 4 millimeters. This is the CBCT, and we can see that there is kind of proximity, very close proximity of the distal root to the inferior canal. What was the treatment plan? Medication, I prescribed vitamin B complex for 1 month. There was no need for any other drugs. I explained everything, and one of the option was a retreatment with attempt to remove the extruded obturation, because it might be one of the reasons for such a nerve injury. Attempt to remove or bypass the fragment, because this was part of the chief complaint of the patient. And the physiotherapy by intentional stimulation of the inferior alveolar nerve by just using a pin and sticking or lip or the gingival in that side, just to stimulate the the sensation of the inferior nerve. Started with the root canal retreatment normal procedure. I was able to bypass the fragment, and I was able to remove the extruded root canal fillings, measuring the working length, complete bypassing of the and dressing, confit, obturation of the root canals, and this is the final obturation. And it's just 5 months since I dealt with the case. I'm still in contact with the patient, and she's feeling a kind of very slow recovery, but not complete recovery. What are the learning outcomes of this case? Please comment and take your own radiographs before you start treating any patient. Inform your patient and assure him or her about any complications. Carefully diagnose, especially by CBCT analysis in such cases. Refer when it's beyond your limitation, if you have limitation. Adhere to RCT precautions. As we mentioned, it's very important to get to measure the working lengths accurately and stick to that working length during the cleaning and shaping procedure, and make sure that the rubber stop is touching the reference point and not going beyond that. These are very important. Adhere to the correct irrigation measures by using endo irrigation needle. Make sure that the endo irrigation needle is not engaged with the root canal walls. Make sure that you don't apply extra pressure while irrigating the root canals. And follow up if you have any, if the patient encounters any injuries. Moving to another issue, which is that some dentists think that the apical thread of the root canal system is the main issue, and in reality it's the coronal interferences are the key. So that means we need to think differently. Once we need to do RCT for a tooth like this, we always think that the problem in the apical third and the apical third, and we will start being carefully once we will insert the file and reach the apical third. And in reality, we need to think coronally. When you think and focus on the coronal part of the root canal system, definitely you will reach the apical third safely. For example, when we try to treat some cases and we try to insert a KFI number 10, we feel that it's not going beyond the middle third and it's stuck there. And we think that there is a kind of calcification, let's say, or narrow canals, or maybe the canal is curved. So some dentists might think to force the file. Once you start forcing the file, you start creating problem, creating glitch. You think that the file is going in within the canal or the original path of the canal, and in reality you created glitch and you start creating artificial canal, which will end up with perforation. And the problem is not with the apical part of the canal, it's almost the problem there in the coronal part. One of them is the what we call it dentin triangle. So we need to remove the dentin triangle either completely or partially, because we need to adhere to the minimal invasive endodontics and preserve the dentin thickness at the cervical area of the tooth. The best way to remove dentin triangle is using ultrasonic tips under magnification, as you can see here, under magnification and with specially designed ultrasonic tips that works only within the pulp chamber. I can selectively remove the dentin that prevent the complete insertion of the K file and reaching the apical third. This is a dentin triangle, as I mentioned, which prevents the K file number 10 or even 8, according to the difficulty of the case, from reaching the apical third. And we think that the problem in the apical third. No, the problem is with the dentin triangle. Once you remove the dentin triangle partially or completely, as I mentioned, you will file K file will go easier to the apical third, and you can measure the working length and continue with the work and get the result that you want. Another myth in endodontics, majority of general dental practitioners, unfortunately, think that magnification is a kind of luxury only for specialists, which is completely incorrect. Magnification is must in daily endodontic practice, and that's what we get. And I know that most of dentists, they got upset of what I'm saying when I say no magnification, no real endo. And I'm going to give you a proof. But before that, please do not misunderstand me. When I say magnification, it doesn't mean necessarily using microscope. As long as you are using any magnification and you are able to see what you do, you need to see what you do. That's what I want, and that's what I always stress on. So either loops or microscope can work. Why magnification in endo? Better photographic documentation, improved position of and ergonomics of the dentist and the patient. We use it for conservative access cavity, locating hidden canals, removing dentin triangle, negotiating root canals, calcification, cleaning and shaping, obturation, all step in endo, whether it's non-surgical or surgical endo, we are using magnification. Is it important and is it a must? Yes, it is. And let's see what is the American Association of Endodontics in their standards. They consider that microscope proficiency is a kind of a standard. And by the way, they changed the standard number 4.8 for from use of magnification technique to the phrase of use microscope. Can you believe that? They are not talking about magnification in they are talking about microscopic magnification, and the standard now is the microscopic magnification. Also, they changed the term about magnification from understanding to in depth, which is the highest level of 3 levels of knowledge. Another thing, just we need to know that with when it comes to endodontic apical surgery, biological conditions and coronal and apical seal, in addition to the advanced technologies, ultrasonic tips, magnification, and biocompatible materials, These factors were or have been considered the main favorable endodontic surgery outcome. And the current literature confirmed that the success rate of endodontic microsurgery up to 94% success of microsurgery compared to 59% of traditional surgery. Example of what magnification can do and can give us in apical surgery and in endo. Let's just see another example about the MB2. When we talk about magnification, we talk about MB2, which is a big issue. Here in this study, for example, it was reported that the MB2 is found in, it was there in 63%. Only dentists were able to find it in 41% when they used loops magnification. By contrast, when they used microscopic magnification, they were able to explore of these MB2s. And the interesting result that whatever we do, whatever magnification, there are some cases that we cannot see and we cannot negotiate. In this study, almost 6% of the MB2s, they were not able or to find even using microscope. In another study, it was reported that the MB2 is there in almost 91% of molars. By naked eye, dentists were able to find only about 54%. And it loops, it was mentioned about microscopic magnification, the percentage of finding the MB2 increased significantly up to 80. Another study that confirmed that the MB2 is there in 94%. Only 69% of dentists were able to find this MB2 when they didn't use any type of magnification, while when they used microscopic magnification, they were able to identify the MB2 in 80%. Another study, the MB2 was there in 90% of cases. Without magnification, dentists were able to find only 64%, but with microscopic magnification, they were able to find 93%. We can see this big difference. One of the latest studies mentioned that without microscope, dentists were able to find the MB2 in 27%, but with microscope, they were able to find 78% of the MB2. One of the study which I believe is interesting study confirmed that microscope help us to find the MB2, but it also helps us to negotiate. So what does it mean? It means that in some cases we get the MB2, but we are not able to negotiate. If you want to negotiate more the MB2 that you find, you need to use magnification. Another interesting clinical study, what they found, they almost examined 1,873 cavities of maxillary first and second molars over 2 years. The MB2, this study about retreatment, by the way, the MB2 in the first molar and retreatment cases in 67%, while in the initial RCT it was in 59%. And for the second molar, the MB2 was in 44% in the retreatment cases compared to 35% in the initial treatment. So we can see that significant higher number of MB2 are found in retreatment cases. And that's why the conclusion of this study was that the significant differences suggest that failure to find and treat the MB2 the long-term prognosis of RCT. When we talk about MB2, that means we have to talk about the top secret in endodontics, and it's no longer a secret, which is the color changes. It is well known that the human visual system is more sensitive to color. So that means we are able to see more detail when we see pictures and photos or any scene in colors rather than when we see them in gray scale, white and black. This is, for example, here when we talk about the upper molar, okay, we know that the MB2 is between the MB1 and the palatal. And this is also another misunderstanding. When we say that, it doesn't mean that it is in that line that we can see that connect between the MB1 and palatal canal. No, it is there in that direction. It's in that is parallel to the mesial wall of the molar. And if the mesial wall of the molar is not there, you can rely on the distal wall of the premolar. So this, in this line, okay, in any distance between the buccal and the palatal, you will find the MB2. It might be here, it might be here, and it might be there. It's not in the line that connect between the MB1 and the palatal canal. Usually it's there in that line. So whenever you want to find the MB2 without preparing any dentine, look in the bulb chamber floor there. And if you want to prepare dentine by ultrasonic, you have to trephine dentine and prepare dentine in this direction. And this is how I found the MB2 in this case. Of course, using magnification and relying on the color changes, and a lot of time were the key factors in getting this outcome. What is the myth here? The myth here that usually we used to believe that calcified canals are dark spots in the field that we see. What I mean by this, whenever we have upper molar like this, what we know that the lateral walls are light. The bulb chamber floor is dark. So if we want to find the hidden canals, which is usually MB2 or even calcified canals MB1 or the distobuccal, if we want to find these hidden canals, we need to look to the darkest spot, because usually hidden canals or calcified canals, usually they appear under magnification as the darkest spot. This is what we use to think. Again, here you can see that the lateral wall are light, the bulb chamber floor is dark, and the darkest are the orifices of the canal. This is what you need to rely on when you try to find hidden canals, and of course, under magnification. What we think that the calcified canals that are mentioned, but in reality, in some cases, even there are little percentage of these cases, they appear as light spot. And here is an example of this. This case was referred to me to deal with upper lateral. The patient chief complaint on biting, had traumatic injury long time ago, almost 20 years ago. And he went to a dentist to find the canal, but he couldn't, because he didn't even, I assume that he didn't take BA, and he was trying to find the orifice of the canal by bears. So he ended up, instead of preparing access cavity in the crown, he prepared access cavity in the root and almost perforate the root without finding the canals. Once I removed the temporal refilling, this is what I found. If I'm going to rely on what we believe that the canal is the darkest spot, I will not find the canal here. I will go to this part, which is not the canal. This is the canal, and this is the darkest spot. So here, the The canal is not the darkest spot. Here, the canal is best spot. And this is against what we usually think. This is after I prepare the canal. And here is, of course, here, because it's complete calcification, every time I advance 2 to 3 millimeter, I had to take another X-ray just to confirm that I'm in the correct path. Another misunderstanding, that root canals obliteration is optional. This is what we used to teach. Actually, this personally, this is what I used to say a few years ago, that the calcification is all. And what we have learned from the daily experience, that the root canal obliteration can be. For example, this case was referred to me. This is a diagnostic X-ray when the patient came to me, because the referring negotiate and find the mesial canals of the first molar. This is going back to the already gross when the referring dentist started. We can see that there is all the root canal treatment. We don't know the mesial canals, whether it was there and the dentist couldn't negotiate and stop there, or maybe defective RCT caused the calcification. We don't know, but what we know, that there is a kind of calcification. I cannot see any canal here in this radiograph. Even clinically, when I was trying to find the canals microscope, what I found in the mesial canals, that complete calcification tissue that were lighter in color, the color of the canal walls. This is after I just started. This is what the K file. The K file. This is the only point that I was able to reach. But under magnification and carefully, I was preparing the calcification that was like a small area connecting between the buccal side of the root to the lingual side of the root. So I was just light spot, and I ended up, I just tried, I get a catch point, let's say, with the file after the K file. This is what I was there. I was pretty sure that I am within the root, but I don't know if I was within the original root canals or not. So I continued, and I reached where the apex locator, that I am there. I just wanted to check that I didn't create any perforation. So I took a CBCT, axial view of the most apical part of the canal after I filled the canal with calcium hydroxide, because I need to see where the calcium hydroxide going after I activated the calcium hydroxide, just to see if the calcium hydroxide will go in another or another path. The sagittal and the coronal view confirmed that I was within the root, but all beside the original path of the canal, which couldn't appear, wasn't appearing on the normal radiograph. And as I mentioned, under microscopic magnification, I was able just to see a calcified layer of dentin light color compared to the surrounding canal walls. Sorry. Finally, I'm going to talk something related to the instrument fracture. When we mentioned about instrument fracture, all all colleagues, unfortunately, researcher and specialists, they say that rotary phase fracture is due to either cyclic fatigue or torsional fatigue only. But in reality, when I went back to the literature and I read almost 200, 250 articles about mechanisms of fracture of endodontic instruments, what I found that there was no agreement on the exact mechanism of instruments fracture. Some of them contributed the fracture to ductile fracture. Other said that it is fatigue fracture. Another study found that it is fatigue and combined failure. Circular abrasion, that a shear fracture. You can see shear fracture. Here, another again, shear fracture. Ductile fracture again. Combined of brittle fracture, shear fracture, and tensile fracture. So we can see that there has been no agreement on the about the exact mechanism of instruments fracture. So we cannot say that it is cyclic fatigue or torsional fracture only. Why this in agreement, let's say, that there is no agreement about the mechanism, the exact mechanism, simply because instruments is a multifactorial and complex process. There are many factors. And as general practitioners, and whether we are specialists or general practitioners, we need to identify the three main components of instrument structure. Differentiate between the stresses, the type of stresses or forces that the file undergo while cleaning and shaping the root canals. We need to identify the itself, and we need to identify the contributing factors. So these three elements of instrument structure are different, and we need to differentiate between them. Finally, and this is the last point in my webinar, if you can just give me 1 minute or 2 minutes. This that all dental practitioners need to stick with. The first line, the basic line, is the knowledge. This is what we know, and during the undergraduate study and during the postgraduate continuous education, we need to on to develop new skills and to update our knowledge and to know new techniques. Then develop new skills. We need to practice more to improve these skills, but on extracted teeth. Then we transfer what we learned on extracted teeth in the hands-on courses. Then we can transfer these to clinical practice, starting with the easy cases, then modify, then moderate cases, moderate difficult cases, and finally can practice what we learned and what we developed and what we practice more and more on difficult cases. This is a learning curve that we need during our career, from day one in the college to the last day that we do and then dentistry. By this, I finish my webinar. Just this is what I do, and I enjoy doing on courses, fully equipped courses. Through the last, let's say, 15 years, I've met a lot of colleagues, different countries in different cities, and it was great pleasure to meet great colleagues. As we can see here, I always enjoy sharing and learning, by the way. When I meet colleagues, I learn from them because we need to share and learn from each other. You can see that all participants are enjoying what they learn. This is what we need to do. And these are my contacts. If you want to contact with me regarding any case, regarding any question, I'm here to answer, and I'm here now to answer any of your questions. I think we have maybe 10 minutes. That's it.
Okay, thank you so much, Prof. Madarati. Thank you for this excellent presentation. Very informative.
Thank
We
you,
learned a
dear
lot.
Dr. Ababel.
Thank you so much. We can open the discussion now for any dentist or any colleague has any question. Let's check what we have. Let's check.
You have to check on comments on the right side.
Yes. Okay. Do you see any question? Yes. Okay, let's start with Dr. Muhammad Abu Khairan. Thank you for this useful lecture. My question: if MB2 difficult to open, like calcified, can we consider it as a biological ceiling, or may be led to fail the treatment, especially in case without lesion or abscess?
Sorry, can you say it again, please?
He is asking if we cannot find or locate MB2.
Okay.
Can we consider it as it is a biological ceiling since it is already calcified? Or if we neglected, it might lead to failure of the case, especially if there is no lesion or abscess.
We need to differentiate between two things. As long as you can see the orifice of the, even if it is calcified, you need to negotiate, to try to negotiate. But the issue is when you can't find the orifice, this is what we sometimes, if we cannot find the orifice, even like if we see it in CBCT, for example, there are some cases that we have to admit, very little cases, MB2 clinically. So what to do? We have to inform the patient, continue with the treatment. Luckily, we are lucky sometimes that the MB2 is meeting the MB1, okay, and they have the joint at the end. So in such cases, things might go well, and we have nothing to do. If in the future any periapical disease develops, that means we will think about the other approaches, which is almost the surgery.
What's the percentage of joining MB1 and MB2?
I can't remember, and more important, I don't care about figures, Dr. Obaida. Frankly speaking, it doesn't matter if it is 1% or 70% joining. Our approach is the same always. And this is, by the way, one of the also the myth and misunderstanding among clinicians. When we talk about MB2, we always are asked, what is the percentage of MB2? Whether if I tell you it is 10% or 90%, we need to consider that it is there and try to find it, unless the opposite.
Okay. Next question: how the inferior alveolar nerve injury can caused by the toxic material? Would you elaborate?
How?
The inferior alveolar nerve injury can be caused by toxic material.
What is the question,
What's
please?
the mechanism? What's the mechanism? How the extruded material? Chemicals.
Chemical, yeah. Chemicals. I mentioned that one of these mechanism is the ion. They mentioned that the ion can irritate the inferior nerve.
From where iron comes? From where? Do we use any sealer with iron?
I can't hear you well, Dr. Ababaida. Can you say it again, please?
You are talking about iron. Which iron? From where the iron comes?
From the hemoglobin, which is from the bleeding. Sometimes when we do RCT, we irritate or we periodontal ligament, and we cause bleeding. This bleeding will lead to we have some blood that will dissolve hemoglobin, and then.
Okay. Okay, Dr. Latifa from Tunis, she is asking, some dentists are still speaking about extra canals. I'm not sure what she's meaning.
Can you say the question again? The connection is still not that good.
Not that good. Dr. Latifa is asking from our members. She's asking, some dentists are still speaking about extra canals.
Some dentists,
Sure
what?
Are still speaking about extra canals. I did not understand her question. What she's meaning.
Due to the connection, Dr. Abida, sorry, can I ask you if you can send it to WhatsApp so I can see what is the question,
Okay,
each question?
Yes,
that will be good approach.
Okay, some dentist. Yeah.
I'm watching my WhatsApp now.
Speaking about the extra counts.
Okay. Some dentists are still speaking about extra canals. Okay.
I'm not sure what she is meaning.
I don't know, but by the way, I'm no longer calling them extra canals. It's these part of the root canal anatomy. So it's root canal anatomy system. I don't believe in the terminology extra. Maybe Dr. Latifa, Prof. Latifa agrees with me that this terminology should not be used. Maybe. This is what I understood from her question. Or maybe Dr. Latifa, if you can text me, is Edita is used for calcification? Okay, this is another myth among general practitioners. When about ADTA and calcification, nothing to do with calcification. What opens calcification is endoprobe, low speed bear, like LN bears, ultrasonic tips. It's about magnification and seeing the field in any other chemicals like irrigants, EDTA, EDTA, or sodium hypochlorite, or even saline. It's just a liquid to flush away the debris so we can see better and differentiate in between the canal and the surrounding areas.
Okay, I think we are done now with the questions.
Okay.
If any colleague has a question, he can still write it on comments, and of course our Prof. Madarati will answer them later on.
My great
thank you so
pleasure.
much, Prof. Madarati. Thank you so much. Thank you so much, Dr. Francisco.
Yeah.
Yes.
Dr. Ababeda, I think maybe, I'm not sure, when in the introduction, did you show video of the sponsors?
Yes, well, I see the videos here. I can repeat it again if you want.
Yeah, please, just, it's again, it's good our group members that we have 8 prizes offered by the great sponsor of this conference, and Dr. Obaida repeat and present our great sponsors. So go on, please.
I will do it again, but we still have last question. Last question is, what's your approach while dealing with big lesion to prevent extrusion of sealer or intracanal medication if we took a precise working length well?
Okay, if we take precise working length and if we stick to the working length and we maintain, we get apical control, that's what we need to do. In case if we don't get apical control or we don't get the apical constriction, to seal the apical third with MTA or any bioceramic material.
Okay. Let's see if we have any other question. I have done.
Okay.
Thank you for your webinar, Prof. Madrat. It was very informative. It was very rich of information. Okay. just let me share the sponsoring company again.
Go ahead, please, and thank you.
Okay, you are almost welcome. Okay.
You have to share the screen.
Yes. Okay.
You need
Wait a
to
second.
share the screen.
Okay.
Dr.
Wait a second.
Ababeda.
Okay.
And,
Wait a second.
If you give me, if you excuse me, I need to leave. Is that okay?
Okay. Thank you so much again, Prof. Thank you so
Thank
much.
you so much,
Thank
Prof.
you, thank you, Dr. Vincenzo. Thanks, all our lovely members.
Okay.
Exactly.
Okay. This is Zark.
Yes.
Okay. Thank you so much, Zark company, for our being the sponsor for our webinars, which is platinum sponsor, and thank you, Dinjoy company, for being our golden sponsor. Okay, I would like to thank also our silver sponsor, Dixis and Coxo, and our bronze sponsor, Ramo Medical and ATs. Thank you so much. Thank you so much again, Prof. Madarati, for being our guest today or tonight. Okay, I would like also to thank Dr. Finzizo, right? Do I pronounce it right? Finzizo?
I can hear you.
Wait a second.
Can you repeat? Yes.
How do I say your name? Finzizo or Finzizo?
I can wait. I put my earphone.
Okay, go ahead.
Okay. Can you repeat, please, Dr. Rabo?
How do you say your name? How do you say it in Italian?
Vincenzo.
Vincenzo.
Vincenzo, yes.
Vincenzo. Okay. Thank you so much. Thank you so much.
Thank you so much,
Thank
Dr.
you. I
Rabo.
appreciate your effort.
Thank you a lot.
It's our pleasure. Okay. Hopefully we see you soon on Real.
Yes, me too. Me too.
Inshallah.
Hope to
Have a good night. Have a good night.
Good night too.
Bye. Bye. Thank you so much for every dentist who participated and took part in this great webinar. Assalamu alaikum.
Thank you a lot. Good night.
Good night.